are going to kick off our panel on interoperability. We are so excited to be here. This will be a conversation amongst friends. We're going to be talking about the progress that Surescripts and the Network Alliance has made with interoperability and record locator exchange. We have an awesome panel of folks that are here to share their expertise and knowledge from working with record locator and exchange. So without further ado, I'm going to go down the line here and I'll have each of the panelists introduce themselves. So starting on the end, we have Dr. Kashyap.
Hi everyone, I'm Nitu. I'm a primary care physician and clinical informatician by trade. I'm the Associate CMIO for Yale New Haven Health, and we've been users of the record locator service for a little over a year now.
Hi everybody, Shawn Miller. I'm the Associate CMIO at Cedars-Sinai Hospital in Los Angeles. Clinically, my background is a hospitalist, board certified in internal medicine, and also clinical informatics.
Hello, I'm Athena Muse, not the Athena behind Athena Health, EMR. But I am here from Tampa General Hospital here in Florida. I'm from IT. I have been working on interoperability for about a decade now, and we have been live with record locator exchange for approximately 7 months.
And I'm Grande with the Healthcare Leadership Council. We are an association in Washington, D.C. We focus on broad-based interoperability policy, and we've been working closely with Surescripts on that for about the past couple of years.
And I'm Dave Castle. I'm the Executive Director of the Care Quality Interoperability Initiative.
All right, everyone, and I didn't introduce myself before. Dragert, Product Innovation, oversee record locator and exchange. So let's jump into some of the questions that we have, and we'll have an opportunity for those of you to ask questions as well. So we're going to start with Dr. Kashyap in Yale New Haven. Can you tell us a little bit about the patients that you serve, and in particular the challenges that you've seen connecting with other entities and getting information through interoperability efforts?
So we're a tertiary care academic medical center, 2,500 beds, 5 hospitals across 2 states in southern Connecticut, and a small hospital in Rhode Island. We have about 2 million ambulatory visits a year. Half of our ambulatory practice is primary care, the other half is more specialty based. And so our challenge happens that we're in between 2 large states, and our patients like to travel. And not all of their data is in our systems, so when we're taking care of these complex patients, we need access to information, and that's not always in our EMR systems. Interestingly, in our state, we also have half of the state has one EMR presence predominantly, but a large number of our smaller hospitals and practices are using other EMRs, which we can't directly exchange data with, so which is where we're seeking other solutions to plug that gap.
It's absolutely true that healthcare is no longer local. That was something we used to say in the early days of all of this, and data has proven over and over again that patients are everywhere, and so are their records and their information. Dr. Miller, can you tell us, when you're treating patients at Cedars-Sinai, where do you go to get information on your patients?
Yeah, so obviously I can speak a lot about the hospitalist world and a lot of my colleagues in terms of finding a lot of data for some of our complex patients. Cedars-Sinai is probably one of the largest community hospitals in the country, but it's also a quaternary referral center, large academic institution at the same time. So we tend to get a lot of different types of patients referred to us from all over the place, generally with very complex problems and lots of things you got to look out for and make sure that you have all the data in place. As a hospitalist, when you're seeing that patient, you get that call from the emergency room and you want to quickly assess the patient. Obviously, the more data, the better, and the faster you can get that data and all the snapshots that you can gather quickly before you do all that hunting and pecking around the chart, the better. we get a lot of transfers from other hospitals, and fortunately we do have a lot of Epic customers. We're on an Epic, and there's a lot of Epic customers nearby, but certainly we have a lot of patients that come from non-Epic EMRs because we're a large community hospital. So we actually have a lot of private physicians in our community that we're serving, and most of them are not on Epic and on all sorts of different EMRs. Some are still on some homegrown EMRs, and some of the names you kind of hear about. And so, I think we've come a long way. The hospitalists have certainly appreciated it and seen a lot more outside information through Epic's Happy Together platform and through Care Everywhere. So we're seeing not just obviously Epic to Epic, a lot coming through the Surescripts RLE product and kind of all the interoperability efforts that are going around our community. So certainly as a hospitalist, we're relying a lot more on that outside information at Cedars, probably more than ever before, especially now that we know that we can find a lot more and not have to ignore the fact that we kind of are missing a big piece of kind of a patient's history or recent visits even. So.
Yeah, certainly a big element in that is maximizing the provider's time. So not going out to try to find information that wasn't there at one point, and certainly in some of those emergency situations, being able to get very quickly the information that you need to treat the patient in the best care possible.
A lot of times you're waiting for the fax from the private office that we may get a referral from a private primary care physician in the community, and you're waiting to have them fax their office EMR information.
Yeah, no,
and so
we don't want that. Yeah.
We don't want that, and I guess we're trying to get rid of faxes. It hasn't happened yet, supposedly, per this morning's report. Obviously, a lot of faxing still going on, but just seeing that record, and even the fact that they just went to go see their primary care provider is helpful information in and itself in the middle of the night or when you're kind of piecing together the patient's story. So it's been really helpful.
I predict at some point there will be a moment where everyone goes, wait a minute, I haven't gotten a fax in a week, so it will happen. Athena, you've been an early user of Record Locator and Exchange. Tell us a little bit about the experience at Tampa using the service.
Sure. So from a technical perspective, the implementation process was very similar to our implementation of the health information service provider, the clinical messaging portal. It was seamless, quick, and it really helped that our project manager spoke our EMR jargon. Oftentimes when we're working with other vendors implementing new technology, that can be a barrier, but in our case, Kelly Turney was very fluent, and it just made for the install and configuration much easier. I would say it was approximately a 7 to 10 business day installation and configuration, and most of the time was really toward testing, and even that went fairly quickly compared to some of our other implementations. And then from a clinical perspective, one of the immediate benefits was that our clinicians were able to see instantly where our patients have been. So Tampa General Hospital, being the only nationally verified level 1 trauma center in the state, we get patients from all, not just local patients, from all over the region, flown in through AeroMed. We also have a reputable transplant center where we get patients from all over the world, Egypt, Puerto Rico, Canada. So RLE has really expanded our interoperability footprint drastically. Just patients come in, some possibly unresponsive in our emergency department, and our EMR is auto-querying Record Locator, Surescripts RLE, and immediately comes back with a list of locations where the patient has been. And if we are electronically connected to any of those entities, we can consume the electronic record in a matter of seconds and make clinical decisions based on that information. The information can be reconciled and behave natively within our EMR. So really agnostic of the EMR, I think RLL has really done an amazing job just helping us see a more comprehensive picture of the patient's medical history.
Yeah, and it was great to hear when we were talking earlier today, you mentioned that the Surescripts location summary, which is what we collect and put together to show all of the locations that we have for a patient, that you've been using that as just a really quick way to determine if a patient is a frequent flyer or not. So that alone is meaningful to know as somebody's walking in the door.
So the entities that we are not electronically connected to, we're still seeing value out of those on the location summary because we now have the ability to do outreach. The location summary from RLE comes back with the contact information for the entity. So we're able to use our non-electronic means to reach out to that entity and pull in any needed information.
Yeah. Dr. Kashyap.
Similar. Our experience has been very similar. It's very helpful when you can see actual data dumped from an entity, but just knowing where your patient's been and who they've seen gives you an idea if this was a cardiologist they saw or a podiatrist they saw, and then there's a phone number that you can call. So one of the ways we've been using this service is to close care gaps for patients who are seen for diabetic eye exams. It's a notorious problem to solve. We don't always get that information, so knowing where the patient's been and finding and actually being able to get that record's been valuable.
Yeah, over time, all of that will be electronically available, but being able to see that quick list is meaningful, and I'm glad to see that you guys have found ways to use that. Fantastic. Dr. Miller, can you tell us a little bit about your providers and the impact that record locator and exchange has had?
Well, I think, again, I think speaking to the acuity of the hospitalist setting, I think getting the information quicker and, and having it there so you can either initiate that phone call or get things going, and knowing that there may be some important information in that physician's office or EMR, and knowing that rather than a few days into the hospitalization, knowing that right away has obviously been really critical and helpful for us. I think as like I said, I mean, again, there's the use cases around the community physicians and just seeing, like, again, getting the full record from them. I mean, there's a lot that we're getting from obviously non-Epic EMRs through that exchange and through Athena, eClinical Works. I think the numbers are, I think it's like 2 million or so over the last year that's coming in, and so we're seeing obviously a lot more from our community providers, which is really helpful in terms of us making kind of some of those initial decisions upon admission. And so it's really been helpful from kind of an acuity efficiency point of view, so we can get things going faster rather than waiting to kind of piece all the, have all the pieces come together. Our patients tend to be, again, as I said, pretty sick. They could be in and out of hospitals quite frequently, and between those hospitalizations, they could be seeing a few providers. And so if you miss one of those provider visits, you may be missing kind of a big part of that kind of post-acute care scenario, or things in between those kind of big admissions. So again, that's been helpful.
Yeah. You're hitting on something, especially with critically sick patients. I've always felt like it's practically a moral issue to put the burden of bringing their data in-house on the part of the patient, and we as the industry need to solve that. The patients obviously have other things that are on their mind that they need to think about, and we can solve that in the background. Dr. Kashyap.
I think you're hitting on a very important point there. The sicker the patient, the more the need to automate some of that information exchange, because they have a lot of things going on. One of the examples that came up very early on when we turned the service on is through our transplant coordinators. We have a large transplant service, and they manage their transplant population of about 1,500 pre-transplant patients very, very closely, and it means they're constantly on the phones, but also in new patient evaluation. The transplant coordinators had an early, close encounter with the record locator exchange in a very positive manner when they had a very young lupus patient who came from out of state, relocated to Connecticut, and came to the transplant center by referral from her other organization. But during the course of her history, forgets to mention some important part of her medical testing. But the transplant coordination goes in and looks at those records and finds that this person has a history of hypercoagulability, which changes the management in the perioperative phase for her transplant, which they would never have known if they didn't actually take that proactive step of easily being able to look into those records, not just knowing that she was seen at a certain center and leafing through pages and pages of a transplant record.
I mean, I think it's interesting, patients, I think there's a growing number of patients that recognize interoperability exists and recognize that maybe there's more stuff flowing or there's more stuff flowing now, so they kind of almost expect it. And there's obviously a lot of patients that have no clue that their records are actually being shared. But, we're getting a lot of patients that are saying, it's all my record, it's all there, it should be shared, it's all coming over, and it's all there. And so the more you can actually say, yes, it is there, I see it, the more you can see, the more you can reassure them that you have all that information. I think it's reassuring when you have a better picture of what's going on with the patient. But then, obviously I think there's still a big gap in terms of educating our patients around how much interoperability there really is, and where your data is flowing, and who can see it, and how useful that could be. And so I think it's interesting that I think there's almost a growing split in terms of patients knowing or not knowing about this interoperability world.
It's always a fun exercise at Surescripts to say, well, how do you explain to someone that doesn't know what you do? And a lot of times when you talk to people outside of the industry, it's like, wait a minute, that's not solved yet? Like, I can do all of these things, but my doctors don't know about my medical information. So there's absolutely different paradigms there.
It's a mouthful to say, interoperability, so makes it harder.
So Dave, we've gotten some fantastic provider, Dr. Ingalls around the value of Record Locator. It is so exciting to hear some of those stories and the impact that we're having. We're going to talk a little bit about some of the other industry initiatives and things going on. So Dave, we've worked closely with Carequality, or founding member years ago, and to establish the governance framework and trust agreements. Can you tell us a little bit about why that is so critical to what we're doing in the industry?
Well, you hit on it, I think, mentioning trust agreements. Trust is the foundation for what we do with interoperability. If you think about what we're asking of provider organizations, there's a transaction coming in off the internet that is saying, hey, why don't you give me some of that sensitive patient data for patient X, and we're expecting them to just say, oh, okay, here you go. That doesn't happen without trust. You have to have a basis for that trust, and across these very broad ecosystems of exchange that we're starting to enable with national services like the RLE, that really has to be strong contractual provisions that back that up. And that's really what the role of Carequality is ultimately, is to hold those contracts and be that governance framework. Athena mentioned an important point almost in passing when she said, and for those organizations that we're connected to electronically, when we find out the locations, we can get access to the records in a matter of seconds. A lot of that is not necessarily all, but a lot of that is happening via Carequality. And the role of Carequality and the role of the RLE, I think, are very complementary. The one makes the other much more valuable. Having the ability through Carequality to reach a very broad set of participants. One of my fellow panelists was mentioning all the exchange that they do with Athena practices and eClinicalWorks users and next-gen users out of their Epic system. All of that is being enabled primarily through Carequality. So being able to get to that information is hugely important. At the same time, Carequality creates this very broad ecosystem of potential exchange partners. How do you make sense of that? The RLE plays a huge role in enabling users of Carequality to be able to actually get to the records they need out of that broad array of potential partners that they would otherwise have to query manually.
Yeah, so we've been thrilled to just work with Carequality to have that trust and that governance framework, and then the role that we play is making sure that you can find the records within that ecosystem. Numerous studies show that patients 60% of the time couldn't tell you where they've been and why would they be able to. And then handling the scale. This is happening at a massive scale and growing, and partners like Surescripts allow that incredible industrial strength level of connectivity that's happening today. Tina, the Healthcare Leadership Council is really focused on measuring interoperability, and I've been hearing, even just in the day today at the conference, all sorts of discussion about the value and the need to measure interoperability. What can you tell us about that?
So the Healthcare Leadership Council really looks broad. I mean, we are a big picture policy organization. We're comprised of health systems, hospitals, health plans, health IT vendors, pharmaceutical device manufacturers, and we really take a bird's eye view of interoperability. And nationwide, are we making progress? And within our membership, and Surescripts is a very big part of our membership, we knew there were pockets of fantastic innovation and interoperability happening. I mean, just this discussion alone shows that information is moving, and it's moving in an advantageous way for both clinicians and patients. So we're very excited about a report that we released just today with the Bipartisan Policy Center. And really the purpose of the report was to really show that progress is being made, that the private sector is committing to certain actions to ensure that progress continues. And really the only way to show that progress is continuing is to be able to measure it and measure it well. We worked closely, BPC and HLC, with the Office of National Coordinator, their measurement team. And we know that we've got a good basket of measures in certain areas, for hospitals, for physicians. But really, to look broadly at success, we need to know, is the information being shared, for example, with long-term care facilities? Is the information being shared appropriately with behavioral health providers? So we really need that full picture of the care management plan for a patient, and we really won't know how successful we are unless we can measure it. So we've got a big job ahead of us to make sure we've got the right measures and that we are able to communicate about them at a national level to both policymakers and folks within private industry, so that we can get a sense of where gaps continue to remain, but really where we can celebrate a lot of the wonderful successes like what we're hearing up here on the panel.
It really is about both. Celebrate where we're at so that we can build from it, and understand where we need to go so that we can focus attention and effort in the right places. And without true measurements in place, it's really, really hard to focus appropriately. You said something interesting about we know it's moving. I always like the quote, Einstein said it, and I'm pretty sure he was talking about something else, but nothing happens until something moves. And so the first level is get things moving and then build on those measurements on top of that.
Yeah, we, for those of you who were in the opening session this morning, I mean, the government representatives really said, well, government's now in the driver's seat on interoperability, with these rules that have come out. And I think our report is going to say, we're here, we're partners, and the private sector is really engaged and really committed and not in the back seat. So
Absolutely.
Partnering.
Absolutely. So Dave, another place of that fabric of getting all of this to work and to solving this is standards, which are critical to ensuring seamless information exchange. Tell us a little bit about what standards we're using and what you think holds the most promise in the future.
Well, the standards that we're using today are standards that geeks would maybe love the acronyms. I mean, they're web services that allow for the exchange of documents via protocols that absolutely work, but can be a little bit more cumbersome to set up the first time. ultimately, we anticipate that the industry will, I wouldn't say move to, because that implies that they will no longer use some of the other standards, but will add to the arsenal more lightweight RESTful web services via FHIR, which is certainly an emerging standard. Ultimately, the standard that will be most successful is the one that we agree on. It really is almost that simple. The standards themselves, they'll work. If you develop a standard, it'll work. It's just a matter of whether people will adopt it. And FHIR looks like it has the momentum behind it to gain adoption moving forward. Ultimately, if as an industry we decide to move on to something else, the main thing is just consistency. Standards can't work unless they're truly accepted as a standard. And I think a lot of times I hear people say, oh, well, there's a standard for that, and they sort of rattle off a body that developed something 5 years ago off in a corner. And my response to that is, well, that's not a standard then. That's a white paper that somebody put out. It's a standard if it's actually being accepted and used in real implementations. And I think the standard that everyone is getting behind in healthcare is FHIR. And it becomes a little bit of a self-fulfilling prophecy where as it gains more traction, then it gains more adoption as well, and in turn gains more traction and becomes a sort of virtuous cycle. Because we believe in it, it becomes the standard that works.
Yeah, I think you said something important there. It's often, standards are critical and important because everybody needs the baseline, but it's often not the rate limiting factor. It's really about how do we convene and agree and adopt as an industry to rally around a thing and make it happen and make it real. So Athena, let's talk a little bit about the rallying about that is occurring with Record Locator Exchange and Care Quality. Tell us a little bit about the results that you've seen and how you've been measuring.
Yeah, so I mentioned earlier that the implementation process was pretty straightforward, but like Tina mentioned, how do you measure that success? And although we were seeing much more documents coming into the system, we need to be able to provide metrics to show our success rate with the RLE product. And we have, since the 7 months that we have been live, we have seen an average 15% increase in established links with external sources. And so what that translates to is approximately 9 million external sources that we have linked with, and that is across close to 9,000 zip codes. So we have also established links with electronically connected, entities that have electronic documents available in 49 states. So we need to find that one state that's holding out.
State.
We think it's Montana.
We think it's Montana.
So I think that says volumes about our success rate, and so the numbers I think speak for themselves. And yeah, so it's definitely expanded our interoperability footprint, but we're still not done.
We're never done when it comes to this stuff. So we'll build it out, we'll improve, and we'll keep tackling all of this. This is anyone that's in healthcare is in it for a lifelong journey to improve the nation here. Tina, for our last question, we're going to go down the entire row here, and I want to build off something that you said, and that's really about celebrating our successes. There's so much where we're spending time talking about what doesn't work and what we don't have and what problems we have yet to solve. And I want to spin that a little bit on its head, and we're close enough to the beginning of the year where in the past year, what is something that we're proud of at your organization in the industry of progress that we're making? And we'll start down at the end with Dr. Kashyap.
Sure, I'll share our local experience. We went live with the Record Locator Exchange after weeks of sort of talking through things, and it was a non-event. It was January 26th that we turned it on of last year, and for us it was a big deal, but for the end user it was like nothing happened, which is the kind of go lives we like, because they see the power that's totally integrated in their record. So our users can't distinguish whether this information is coming from the Care Everywhere Epic to Epic network or the Record Locator, because it's just so seamlessly integrated. our technical teams had to do very minimal work. Rather than connecting with individual EMRs, they have a single point of contact. And I repeat that, a single point of contact across multiple EMRs. So we're not making connections. And then because of the standards, the information is displayed in a nice format, which is the same across, regardless of the number of sources that we're getting information from. In terms of celebrating, the numbers are staggering. You know, in the first week, we were able to show how many informations, TCDs, or the continuity of care documents we were able to exchange, and connections we were able to make. I'll distinguish that for those of you who missed what Dave was saying earlier. When you find a patient that's a potential match, the two systems have to say, hey, I have a match. What do you know about them? That's the identification. And then the system will say, well, hey, what can you get me about this patient? And that's where the participation with care quality becomes important. If you are a participant, you can then give us a payload of that information that's much, much richer. All of that is happening within a few seconds. So that's the power on the technical. If you want to geek out on this, happy to indulge. On the clinical side, I mentioned a few of those stories, but it's really those that bring home the point of having a broader access to a patient's information across their continuum. We're also organizationally trying to take that information and incorporate that into our registry metrics for utilization. For example, now we know that a patient is a high utilizer because they weren't going to our EDs, they were going to an ED that we never knew that they were. So we can assess their risk much better through those, leveraging those systems. So that's kind of the systemic work that we still have ahead of us. And if there's anyone in the space of post-acute care, here's my appeal, since I have the microphone, that still remains a black box, and it is really hard to get information. Short of a person picking up a phone and calling back again, we really don't have a good way to exchange information at that rich level with organizations in that space. So certainly work ahead of us.
We just brought live on Record Locator a very large EHR surveying the post-acute care space, so we'll make sure that we...
Awesome.
Yes.
Hot off the press at HIMSS.
Yes. Dr. Miller, looking back.
I mean, echoing kind of a lot of the same sentiment. I mean, I think at Cedars-Sinai, we're pretty proud of a lot of our interoperability efforts around a lot of the connections that we've made and a lot of the growth and sheer volume of information that's coming into our system. I think we were one of the early customers for RRLE, and it was NRLS before. Thanks for making the acronym a little bit shorter so we can understand. We're bringing in 20 plus million documents last year. We've made some successes around, we had to fight a little bit around the auto query piece, and really it was very much a provider pull type action with Epic to get some of these documents in front of them into that clinical workflow. And so the auto query piece has really helped, both querying around our organization for information that's relevant to the patient, and then also around the patient's home. So depending on where they're coming from, there's a radius around auto querying. So we're getting a lot more information in front of our patients. And so, I think now that we have all this volume, I think I definitely want to celebrate that and recognize that we're seeing a lot more, we're getting a lot more information, but it's really, digesting it. And then, I think the big piece, we are also trying to be at the forefront in a lot of that patient sharing and that giving that interoperability back to the patient. So, sharing it through our portal, sharing it through Apple Health and all the other, stuff that people are talking about. So I think there's been a lot of success in that. And so I think if we could help with the digestion of all this information that we now have, I think that would be looking to the future and saying, how does everybody make sense of it, both the clinicians and the patients. But really proud of the amount of volume and the amount of information that we're kind of receiving into our system. It's really been rapid growth recently. So.
Absolutely. Athena.
Yeah, so I mentioned earlier that Tampa General Hospital is a pioneer, a regional pioneer. So relatively speaking, we really are pioneers in the interoperability space. And we've implemented multiple platforms for exchange, but it wasn't really until we connected with RLE that we have essentially removed the blindfold. And we can see so much more on the patient where they have been. So I mentioned earlier also that we're not done yet. So we would really love, as one of our goals, is for that location summary document to be more electronic pulls and less, let's get off the faxing, and let's be able to electronically consume. So I think the rule that was announced earlier this week will help us move in that direction. And also when we look at that location summary and we find our referring partners that are frequently falling on there that we're not electronically connected to, we're putting a process in place to reach out and maybe connect via Care Quality or some other platform so that we can stop the faxing and move toward electronic interoperability. So
Absolutely.
that's our goal.
Tina.
So I come up about a gazillion feet and look at success over the year from a big picture standpoint. And I really think it's this movement from volume-based fee-for-service care to more of a outcomes-based, holistic, care-coordinated model that we see so many of our organizations moving towards. And really, you cannot do that well if the information is not flowing. So I think that this movement towards value-based care and value-based payment arrangements is where the future is going. And the only way it's going to happen is if the information flows. And we see it all starting, and it's very exciting.
Thank you. Dave.
So I'll preface this by saying that volumes of transactions and things like that are at best an imperfect measure of progress. They don't necessarily mean that there was more value to be had there. However, we'd certainly like to believe that the more we're doing, the more information that's flowing, the more value is being found by someone out there. And so for Care Quality, over the course of 2018, we went from a certain number of documents that had been shared all time, starting in July of 2016, so over about a year and a half. That number, we now see double that number exchanged in any given month. And that obviously is continuing to grow. So the rollout of more and more organizations participating is a big driver of that. And also a significant event that occurred for us in 2018 was several go-lives by a number of new networks that are connected into Care Quality, one of which was the Commonwealth Alliance, which brought with it some new vendor partners that had not previously been connected into this Care Quality ecosystem. So that now, in addition to some of the other vendors that were mentioned, Cerner sites, Greenway sites, and in the future others who are members of the Commonwealth Alliance will also be accessible through the same overall structure. So that was a real milestone for Care Quality, and I think for the industry as well, in terms of bringing together really all the major players, I suppose, is always something that's a dangerous thing to say. But I think it really does bring together a huge critical mass of participants that are accessible through one platform. If you're on the RLE, it gives you a lot of access into all of those different sites.
Yeah, a lot of you spoke about just the amassing of volume, and I can remember in the early days of standing up the service, I had some conversations with health systems and physicians that said, I need the data, I want the data, how am I gonna handle it all? And I said, well, I can promise you I'm going to bring you volume. Like, I can promise you that is going to happen, and I can also promise you by accepting that volume and bringing that in, we are going to create a new level of demand and business case to change the usability and the way that it's handled so that we get to maximizing, again, the provider time and getting that time focused on the patient. And so it is one of those things where I think it's gotten a little difficult with the volume, but now we're coming back around and designing software to handle that in a way that is smart. So I think we're going in an era of seeing massive improvements in that space as well. So one thing that I'll share from Surescripts' perspective of progress, many of our customers have invited us into their health systems, into their homes. We've been able to walk the hallways, talk to physicians, and understand stories of how they're using the service. And it has been probably the most humbling experiences for us to hear the impact that the service is having, and oftentimes maybe not even knowing that, who Surescripts is or what they're doing, but they're using it, we see it, and we get to see those stories, and it really just brings a tremendous amount of meaning to the organization here and what we're trying to do in serving providers that are the finest in the country and bringing consumers and patients what is a moral issue to them to have this taken care of by the industry, and instead of their notepads and their 3-ring binders that we've seen all too often carted around doctor to doctor. So really, really exciting stuff. I want to thank my panelists for being here and sharing your stories and sharing your expertise. We are going to now open it up to some questions from the team here, right up front.
So you did a really nice job of talking about the whole electronic record. You addressed the whole electronic record, but given that it's Surescripts, how about medication reconciliation? To what extent can you now just get all of the data about all of the medications that the patients have had?
Yep, we have the largest, cleanest, highest quality repository of medication history in the industry, and we are sharing that millions upon millions a day with physicians. So it's a different standard, it's a different part of our network, but that is something that is absolutely core to what we do in a different format. And then of course medications also come through as a part of CCDAs that are exchanged with Record Locator as well. Nitu, you want to add?
So what product is that?
Medication history. We have a, yep, and I can connect you with someone here that would love to talk to you about it. He's waving right there. You want to talk to that guy?
That's been a huge advantage and a major asset for us, that product around being able to see the Surescripts information and prescriptions that have been either prescribed around the community, and it's really we've built it into our Epic navigators and our workflows. Now we're fortunate enough to have a lot of programs that have pharmacy technicians and pharmacists do a lot of the med reconciliation with us, either through admission or prior to discharge, and they heavily rely on the Surescripts product to get some of that prescribing information, especially when the patient can't give us that information themselves, or you can't access family, and so that data is a big part of kind of our whole complete med reconciliation process. Fills in a lot of gaps.
So I'll add on 2 aspects. One, we have a similar process in the hospital where we use the dispense history to collect the prior to admission medications when the patient comes in, and we have pharm techs doing that in the ED together. And it's a standard operating procedure for them now, with minding what they can sort of take in, but they can't remove any part of that history because of their license requirements. So that's very, very valuable on getting an accurate med history, which is the start of a good medication reconciliation, but it's not med reconciliation by itself. It's just the very, very first beginning. So that, but it is a valuable part of it. I will add that at the state level, we have had a group under the health IT officer that's been working to address that very issue at a statewide level, from large systems to individual practices to the VA at the table, having the discussions, and Surescripts is part of that discussion. I don't have anything to report back to say we found a magic solution for it, but that is what we're looking for, a place where we can get a good, accurate med history for the patient, and that includes whether they paid cash or it was through their payer or it is an over-the-counter medication, anything that the patient's taking, and be able to make sure that any changes that are made to that med list are reflected across their shared provider space. So it's not like I changed the med and Shawn never heard about it. So, or the pharmacist down the street never heard about it, so they continue to do auto refills. So not an easy problem to solve, but nevertheless doesn't stop us from trying.
What other questions?
Dr. Miller, you said that you had patients that expected that you would have their data, and then you also said patients didn't know data was being exchanged. What about the third column, patients who don't want their data exchanged? Do you see with the increase of information that you're getting in that you're having more patients saying that you don't want them to share your data, and how do you handle that?
I wouldn't say it's common. I mean, you're right, that is a third category of patients, and we occasionally hear about patients that are surprised to find out that it just kind of seamlessly went from UCLA down the street to Cedars-Sinai, and I don't want that information shared. Now, there is an opt-out process, and there's certainly within our Care Everywhere framework, patients can kind of opt out of that sharing. The socialization around that and getting ahead of that for patients is probably not something that we heavily focus on in terms of educating patients that they can opt out. But different organizations have a different approach, and I think different organizations have a different risk tolerance, I think, around that. Even the consent piece, through our Care Everywhere platform and Epic, there are rules of the road that every organization has to follow, but some organizations also do require consent, some don't, for the patient to actually allow their information to be shared. So I think it's case by case. It's interesting, even some doctors actually get concerned a little bit. We hear from doctors that I don't want other doctors seeing information as well. And so there's, even some, it's not a lot, but I think there are even some physicians that are pretty conservative around information sharing and not necessarily seeing the value of kind of sharing, or even just the medical necessity of sharing some of that information. So an important category, but we haven't found it to be a very significant number. It's just when it does happen, there is a path to, if they really don't want their information shared, they can opt out.
I can add to that. So Tampa General Hospital is also on Epic. We're also using Care Everywhere. And shortly after our go live, we started tracking those metrics, and we had an average 2% opt out. So most of our patients were opting in to share their information. And we are requiring authorization to share their record, while some of our Florida partners do not always require the authorization, and still we were having similar metrics as far as our opt-out rate.
And I think a lot of the, just as a quick follow, I think there's been a lot of discussion around this with the VA and opting in rather than opting out for patients. And we were very excited to have a lot of connections with the VA system, and unfortunately found that the volume was really not there because of that issue around patients. And I think there is discussion within the VA system and legislation changing. I think they're going to flip to more of an opt-out process, and so I think it certainly seems like the right way to go, but I guess always having kind of an opt-out is important.
I'll say ditto. That's
To add to that, the legislation actually has changed. The VA's implementation of it is outstanding, but it's interesting to look at as an example case. It really did greatly limit the value that the VA saw from interoperability, and their hands were tied legislatively until very recently. But it's a case in point. If you want to gain value from these exchanges, having those patient consent steps in the way artificially, I'm not saying that you shouldn't be respecting the patient's wishes, but having that sort of artificial, everybody must take a more arduous opt-in step, you just have to be aware that that's going to limit the value of the connectivity.
Yes. State rules withstanding, which they vary from state to state, and so you get into, well, what do I do when I'm crossing borders? There's a lot of that to work through, and it's complicated. But Athena, you said something that shows up in study. It's about 2 to 3% of patients that just philosophically will not ever want to share, but it's a small percentage.
And there's a reason the
Federal privacy rule operates on something called implied consent. When you show up for treatment, you're implying, yes, I want to be taken care of. I want my care to be paid for. And I want my hospital or doctor's office to be able to function on the operations side so that I can receive high quality care. So that's at the federal level. We operate on implied consent. There is going to be a broad national privacy debate this year, and we'll see it unfold in Congress, and it will be very interesting to see how it all pans out.
Absolutely. And we'll have lots more volume and activity to inform that dialogue. There's a question over here.
I wanted to go back to something you pointed out a minute ago. Drug seekers that used to skate the system by paying cash, non-insurance. You mentioned that that's no longer possible. How did you take measures to correct that?
I personally didn't take those measures. I think Surescripts did on our behalf. What I learned recently was that we do get that dispense information now from Surescripts that we didn't get in the past. It is a new development. That is my understanding. I'll let Surescripts confirm for you. Cash payments for medications.
So yeah, so our medication history is showing dispenses, cash. I mean, we are amassing, what we tend to do is amass multiple sources of data and funnel it into our products. So we have a variety of ways of getting information, cash pay prescriptions being one of them. And I would also say our location summary is showing you the different frequent flyers that may be showing up in other places as well. Yeah. Thank you, everyone.